Good morning, everybody. Welcome to today's grand round. We really have the pleasure to have Dr. Mariam with us, the dermatologist, who will give us a topic about beyond the pain with fibromyalgia, which is one of the most toughest actually diagnosis because it's usually an exclusion. And everybody probably knows Dr. Mariam. She's been with us for 1 year. She's doing a great job. One of the most active and hardworking physicians we have here in Ali under the medical department. Welcome, Dr. Mariam.
Good morning, everyone. Assalamu alaikum. Thank you, Dr. Jamila, for the introduction. So today I'm going to talk about a topic that, as Dr. Jamila said, it's very challenging for us rheumatologists and for everyone who's dealing with patients, GPs, family medicine, ER, because it's a very complex disease and it's easily disregarded. So that's why I would like to educate everyone about it today. What's the pointer? Should I? And yeah, thank you. Okay, so this is my agenda today. We're going to dissect fibromyalgia from all aspects in order for us to really understand it. So let's start with the what. What is fibromyalgia? So fibromyalgia is defined by chronic widespread musculoskeletal pain. It is part of a syndrome that is called the central sensitization syndrome. What happens in central sensitization syndrome? Your perceived pain, so the fibromyalgia patient perceived pain is higher than the expected reaction that comes from normal healthy controls. So it's not just the pain, that's the topic of us today, it's beyond the pain. So it's associated with cognitive disturbance, fatigue, psychiatric and somatic symptoms. So the why, why does it happen? We don't know. And that's part of the challenge. When we don't know how fibromyalgia happened, we don't know, it's very difficult for us to recognize it and treat it. But there are some proposed pathophysiologies, like there is a deficiency in the endogenous analgesic system. Some triggers that were proposed, like multiple physical or emotional stressors, infections, inflammation like rheumatological diseases, emotional or physical trauma. Possible risk factors are genetic predisposition. So if one of your family has fibromyalgia, you're more likely to have it. If there are underlying rheumatological diseases, if there is also some recent studies found that high fat mass and low muscle volume is also associated with the development and severity of symptoms of fibromyalgia. So who gets it? Of course, females get it more than males for many reasons. It's common between 20 and 55 years of age. In the US, the prevalence is 6.4%, which is very high. I found one systemic review from Saudi, and the prevalence is even higher in Saudi, is 13.9%. I tried to look for Bahrain, I didn't find any data regarding that. So how does it happen? Let's go into the pathophysiology. So in normal people, if you have a normal touch, the signal is sent to the sensory cortex and a touch sensation is developed. In fibromyalgia patient, a normal touch or in like slightly painful situation, it's a different exaggerated response and a pain sensation is interpreted in the sensory cortex. And this is due to many reasons, and these are also proposed. The high glutamate and substance P, which is a nauseous stimuli, low serotonin and norepinephrine, which is kind of an analgesia, prolonged enhancement of pain. So it's not just a pain sensation, it's also prolonged and exaggerated dysregulation of dopamine and alteration of brain endogenous opioids. So what can we do? So first, we need to approach patients with fibromyalgia by history and physical exam. So you ask for these. As we said, the hallmark is the musculoskeletal pain, but it's also present with fatigue, of cognitive disturbance, and depression and anxiety and other symptoms. So let's dive into the pain. As we said, it's widespread musculoskeletal pain, can be bilateral, upper and lower limb. It starts as localized, but then it becomes generalized. Neck and shoulder are very prominent in fibromyalgia patient, and it also may overlap with joint pain. So how can we in physical exam elicit this pain? This is the famous tender points that most of you, I think, you know about them. So there are 18 points that were defined in 1990. We call them tender points, where the clinician should go and touch one by one, and then once the pain is elicited, then you count them as a tender point. In 1999, the American College of Rheumatology diagnostic criteria of fibromyalgia proposed having 11 out of 18 tender points as diagnostic of fibromyalgia. But what is the limitation here? We said that fibromyalgia is not just pain, so it's disregarding other symptoms of fibromyalgia. Also, it's different technique between physician and physician that might not be accurate. And also 11 tender points is very high bar to diagnose fibromyalgia, so most patients will be disregarded if we use the ACR 1990 criteria. So the updated in 2010, then updated more in 2016, is the widespread pain index. And the difference between the tender points and this, it's an area. So it's not just a point, it's an area. And we have 19 areas now, not 18. And then you ask the patient, have you had any pain or tenderness during the past 7 days? So it's not just during the clinical visit, but also during the past 7 days. And you mark them here and you have a score. Now, this is pain. Let's go to fatigue. So fatigue is one of the most challenging symptoms that comes to our clinic. It's a vast differential diagnosis, it's not specific. It's very hard to elicit in history and physical exam. But in fibromyalgia patients, typically their fatigue starts from the moment they wake up. And it can also present mid-afternoon. It's minor activity can precipitate it. And even prolonged activity, inactivity. So if the patient is sitting for a long time, they might get also fatigued. It's also associated with disturbed sleep. So their sleep is usually light. They have frequent night awakening. They're feeling unrefreshed. And even after a good night's sleep, they're feeling unrefreshed. So you have to elicit all these symptoms when you take the history. Cognitive disturbance is famously called in fibromyalgia as fibrofog. They're unable to concentrate with and perform tasks that require rapid change in thinking. So it's very difficult to concentrate. Now, other symptoms are psychiatric symptoms like anxiety and depression, headaches, numbness with normal neurological evaluation. It's fibromyalgia is famously associated with irritable bowel syndrome, so you need to ask about this because they almost share the similar pathophysiology. GERD and other symptoms like CK symptoms, which is dry eyes, dry mouth, palpitation, dyspnea, and dysphagia. So in order to elicit this in the physical exam, there is something called symptom severity scale score. So this adjusted what the tender points didn't take into consideration. So we do the widespread pain index, and then to elicit other symptoms, we do the symptom severity scale score. So this takes into consideration fatigue, the cognitive impairment, and the feeling unrefreshed. And then the patient gives a score from 0 to 3, and based on the score, we calculate the score. Now, section B talks about IBS-like symptoms, pain, cramps in the lower abdomen, depression, and headache. So all of this will be taken into consideration when deciding if the patient has fibromyalgia or not. So this is how we diagnose in the end. We use those two scores, the widespread pain index and the symptom severity scale score. Because clinically, we can only diagnose these patients. We cannot use them. We don't have a serological test like rheumatoid arthritis to do rheumatoid factor or anti-CCP. We don't have an imaging technique. We can just do an EEG for a patient and see if they have fibromyalgia. So the only thing we can depend on is the clinical diagnosis. So we use the widespread pain index, the one we spoke about before, and then we add it to the symptom severity scale, and then depends on the score, it's suggestive that the patient have fibromyalgia. But we need two other criteria. One is that these symptoms is not recent. It's been there for the past 3 months. And the other most important symptom, do we have another explanation to these symptoms that the patient is complaining of? So that's the problem with fibromyalgia. It overlaps with many rheumatological diseases. It mimics many rheumatological diseases. And in order to diagnose it, we have to exclude many other diseases before labeling the patient as fibromyalgia. So we look for other explanation for the symptoms. I'll start with spondyloarthritis because this is, as a rheumatologist, is the most overlapping thing we see with fibromyalgia. Why? Because if you look at this picture, I just showed you the tender points. It looks like it. It's actually a different score. It's the enthesitis score, which is common in spondyloarthritis. So these are also tender points that we look for that shows us inflammation in the tendon that is attached to the bone, what we call entheses. So that's why it looks similar to fibromyalgia. And what makes it more challenging, fibromyalgia is very common in spondyloarthritis. So sometimes it's very difficult to differentiate between enthesitis and fibromyalgia. Hypothyroidism can present with similar symptoms, the headache, the depression, the fatigue. It's also common. Vitamin D deficiency can be the same. And then you also look not just if there is another explanation, is there something else that is there with fibromyalgia that is inciting the fibromyalgia? So we have to search for underlying rheumatological disease. The most common rheumatological disease that comes with fibromyalgia and fatigue and depression, all these things is Sjogren's syndrome. It's very much ignored and forgotten about. So that's why you always need to look for it when you have a patient coming with you with these symptoms. So now the management. The most important thing is you yourself as a clinician, and you tell your patient that they have a real disease. And I think that's mostly forgotten. Most patients, when they come to the rheumatology clinic, we try to dig for the inflammatory arthritis. And do they have lupus? Do they have Sjogren? And then when all the tests come back negative, we're disappointed as clinician because we didn't diagnose them. And maybe we don't relate to the patient that their symptoms are still there. So the patient comes in pain, even if their lab tests are negative, they still have pain. So we need to tell the patient, yes, you don't have what I was looking for, but you have another entity called fibromyalgia. So once you do this, that's 50% of the treatment. You reassure the patient that they're not imagining their symptoms. It's not just about the pain. As we said, you approach the fibromyalgia from all aspects. You have to manage the underlying condition of any. So if it's rheumatoid arthritis or Sjogren's syndrome, you have to also manage it in order to control fibromyalgia. Unfortunately, research is very rare in fibromyalgia, especially randomized controlled trials. So most of the evidence I'm going to present now is weak, except for exercise that has strong evidence of improvement. So again, fibromyalgia is a real disease. So by the time the patient gets to us, they've been shopping around in rheumatology clinic, in GP clinic, in family clinic, and every one of them, they did the whole battery of tests, and they tell them nothing's there, everything is normal, but the pain is still there. So what I do usually to my patients, I tell them about fibromyalgia. I explain to them the slide of the pathophysiology, that there is a problem in the wiring, there is a problem with neurotransmitter, this is what's causing you the pain. And then I tell them, this is the only condition I say that go Google about fibromyalgia. This is the only condition I do this. Because when they read the symptoms, it actually fits their symptoms. So they feel, okay, like someone else having these symptoms, it's not just me. So this reassures the patient greatly and helps us in the also future slides and the management of the other things that we're going to do. So your aim should be to improve the quality of life of your patient. And don't forget about the depression, the fatigue, the sleep disturbance, and the comorbidities. It's not just the pain. So all the pieces of the puzzles need to fit when you're managing your patient. So let's start with non-pharmacological. And actually, non-pharmacological have greater benefit than pharmacological, but unfortunately, sometimes it's not enough. So we need to go to the pharmacological. So as we said, the only strong evidence on the management is on exercise. The strongest evidence on aerobic and strengthening exercise. It helps both the pain and the function. The other pharmacological is cognitive behavioral therapy. It also helps the pain and the function. Other non-pharmacological management is multi-component therapy. So if you combine psychotherapy, psychiatric therapy, educational therapy with exercise, it's shown that it helps pain and fatigue. Acupuncture also has shown to help pain and fatigue. Hydrotherapy helps pain, proven by studies. And meditative movement, which is yoga and Tai Chi, help both fatigue and sleep. So you combine these things when you tell your patients about them to hopefully address all their concerns. Now, when we did this and it's not working, we go to the pharmacological. So one of the most highly used treatment is amitriptyline. It's a tricyclic antidepressant, the low dose, 25 milligram. So studies have shown it helped greatly with the pain, some with sleep, moderately with fatigue. So at least you'll be addressing three components. Duloxetine or milnacarpine, which are SNRIs. These help greatly with the pain, some with sleep and some with function. Tramadol, as you know, it is an opioid. It helps with the pain. Pregabalin, it helps greatly with the pain, some with the fatigue and some with the sleep. And then these things, studies either were not sufficient to conclude that they have any benefit, or the studies have shown there is no benefit. So chiropractor, massage. I know many patients enjoy having massage. It's not harmful; they can do it. But studies didn't show any benefit when it came to managing fibromyalgia. Glucocorticoids is also there. There are no studies regarding glucocorticoids and fibromyalgia, so we don't usually use it. So now this is just a summary of everything we said. So this is how we approach. We start with the history and physical examination. Once the diagnosis of fibromyalgia is there, you need to make sure that you exclude the treatable comorbidities if it's suggested. So labs, radiological exam, and you refer to other specialties, rheumatology, neurology, whoever that's have a disease that might fit a different diagnosis. You start with patient education and information sheet. Some patients actually with education, they become better, but if not, then you go to physical therapy. And then with the other non-pharmacological therapy we spoke about. If it's insufficient, you go to the reassessment and tailor individualized treatment to this patient. And you can add pharmacological therapy. So it depends on what the patient has. So if, for example, it's severe pain with sleep disturbance, if it's severe pain, you go with the things that work mostly on pain. So the duloxetine, which is Cymbalta, pregabalin, which is Lyrica, and Tramadol. Then if it's severe sleep problems, you need something that have a sedative effect. So you go mostly with amitriptyline or pregabalin at night. If the patient is mainly having depression and psychiatric symptoms, then our colleagues in psychiatry will help us out. So we go with the CBT and pharmacological treatment aimed at depression. If it's severe disability with sick leave, then this is where rehabilitation comes into consideration. And this is it. Thank you very much. Any questions?
Thank you so much, Dr. Mariam. As I said, this is one of the most probably difficult diagnoses, not only diagnosis and management, because we really don't have much to offer the patient that will change their life.
True.
My question, this is really very important because now with the COVID-19, we have the long COVID syndrome, which is much overlapping with it. And it's difficult to differentiate,
100%.
difficult to really address. So what's your perspective? Because we are seeing a lot of long COVID and most of it presented like fibroid.
Exactly. I actually came into contact with one study that put long COVID next to fibromyalgia, and in the pathophysiology they've seen similar neurotransmitters, and it looks exactly the same even in MRI. Like they did MRI, there are a few things that don't light up with functional MRI. With fibromyalgia, it's the same with long COVID. So the approach will be, to me, the same, because we don't have anything else when it comes to long COVID. It's a new disease. So because it shares similar pathophysiology, then we can apply some of what we know about fibromyalgia and long COVID if the symptoms are suggestive. Because I know that other treatment didn't work with long COVID, but definitely it's in the same category, like under central sensitization syndrome, 100%. Yes, Dr. Franz.
Thank you for an excellent presentation. We are actually treating several patients at the moment with fibromyalgia as part of long COVID.
Okay.
And in the middle of March, we have a neurofeedback practitioner from the United States coming over so that we can combine neurofeedback or neuromodulation with hyperbaric oxygen and a pro-dopamine regulator. So we really like to work with you on this.
Sure,
because it
100%.
is very promising.
100%. Anyone else? anyone has fibromyalgia, they want to share their experience. Many physicians have fibromyalgia. There is one study actually from where I trained in Qatif. They did fibromyalgia in COVID times. And the prevalence of people who were frontliners in COVID time of having fibromyalgia is more than the people who were like in the call center, for example. So of course, people in the healthcare setting, they have fibromyalgia.
It's not fibromyalgia, it is related, it's side effects of being physician. So that's
It's not a pandemic.
It's normal. When you touch us, we scream, but that's this is how we do it.
Okay. Then thank you very much.
Thank you so much.
Okay.
Thank you.